Hey team, welcome back to Pick University. Today we're going to continue our review of the 2020 Surviving Sepsis Campaign Guidelines for the management of septic shock and sepsis-associated organ dysfunction in children. And today we'll be reviewing the recommendations regarding fluid therapy and hemodynamic monitoring. So the campaign breaks up their guidelines for treatment of septic shock and sepsis-associated organ dysfunction into two arms. And those are based upon whether or not your institution has ICU availability. And we'll talk about the reason for that in a minute. But the recommendations are that if you have ICU availability in your institution, in the first hour, you should plan to administer 40 to 60 milliliters per kilogram of crystalloid fluid resuscitation for patients who present in septic shock. And these resuscitations should be guided by measures of cardiac output, including heart rate and blood pressure, capillary refill, level of consciousness, and urine output as signs of end organ perfusion. Now, fluid resuscitation should be discontinued or paused if patients start to develop signs of fluid overload. And these include things like pulmonary edema and hepatomegaly. Now, if you practice in an institution where there is not ICU capability, the algorithm changes somewhat. And that is that patients who present with sepsis-associated organ dysfunction but have normal tension should not receive any IV fluid boluses. Rather, they can be started on maintenance IV fluids and monitored for need for ancillary therapies. Now, patients that present with septic shock with hypotension, on the other hand, do require slightly less aggressive fluid resuscitation without ICU capabilities. So they, according to the recommendations, should receive up to 40 milliliters per kilogram of fluid resuscitation, again, titrating those measures of cardiac output and fluid overload. And the reason for this distinction between availability of ICU capabilities or not is based upon something called the FEAST trial. And so the FEAST trial was performed in sub-Saharan Africa. And this was a low-resource setting where they studied children who presented with septic shock and administered either aggressive fluid resuscitation or just maintenance IV fluids when patients presented to them. And they actually found that these patients in a low-resource setting did worse when they received aggressive fluid resuscitation when they had septic shock. And so this was quite a surprising finding, and people think that the reason behind this was that patients that did receive aggressive fluid resuscitation did sometimes have deleterious outcomes because of that. So we know that giving large amounts of IV fluid, such as 40 to 60 milliliters per kilogram in a patient who has perhaps cardiac dysfunction and capillary leak can lead to respiratory failure and other deleterious side effects. And so patients that do not have the availability of such as mechanical ventilators or other therapies such as vasoactives perhaps receive more fluid than they're able to tolerate. And so we have to understand that while some patients need aggressive fluid resuscitation, not all patients with septic shock can tolerate fluid resuscitation without the use of other ICU therapies. So that's the underlying reason for this bifurcation in these two arms of their recommendations. Now, in terms of the actual fluids being used, the campaign suggests the use of crystalloids over albumin. So the reason for that, again, was based on the FEAST trial, where they found that patients had no difference in mortality when administered 5% albumin versus 0.9% saline. And we know that albumin itself is costlier, less readily available, and more of an infectious risk than 0.9% saline. However, additionally, they also made the recommendation that patients should receive balanced or buffered crystalloids versus 0.9% saline. And that is because some studies have shown that 0.9% or normal saline has been associated with hyperchloremic acidosis. That is an acidosis directly related to their levels of sodium chloride, as well as systemic inflammation, acute kidney injury, coagulopathy, and mortality. Additionally, they make a note to recommend against the use of hydroxyethyl starches, which are made from maize base. These are colloids as well. And they also recommend against the use of gelatin, which was historically used as another colloid type product. Now, just to review, normal saline is composed of approximately 154 milliequivalents per liter of sodium and 154 milliequivalents per liter of chloride. This is in contrast to lactated ringers, which has 130 milliequivalents per liter of sodium, and plasmolite, or balanced or buffered crystalloid of another type, which only has 140 milliequivalents per liter. Additionally, lactated ringers and plasmolite have significantly less chloride, which leads to less of that hyperchloremic acidosis that we talked about previously. So that is why lactated ringers and plasmolite are thought to be more beneficial than using 0.9% saline. Now, in terms of how you're monitoring this patient and how they're doing in their resuscitation, the recommendations are that based upon adult studies where they found that adults had a benefit in mortality when clinicians targeted a mean arterial blood pressure greater than 65 millimeters of mercury. Now, we do not have direct randomized control trials or other robust data to see that compares in pediatric studies. However, survey data of practitioners shows that about 37% of practitioners target anywhere from the 5th to the 50th percentile blood pressure when they are resuscitating patients, and 45% of practitioners target a blood pressure greater than the 50th percentile. Now, these are not hard and fast goals, and in fact, the campaign makes a special note to say that you do not have to have strict blood pressure goals if you have improving hemodynamics and measures such as improving mental status, urine output, or other end organ perfusion. And that kind of goes along with that thought about the FEAST trial and how fluid overload can be deleterious for these patients. Now, in addition to the blood pressure targeting, they make a special note to talk about our clinical assessments. And so previously, the Academy of Critical Care Medicine made a recommendation and actually based a lot of their algorithm on whether patients had warm shock or cold shock. And this assessment or determination was made by the temperature of a patient's extremities, the strength of their pulses, their diastolic blood pressure, and their pulse pressure. And unfortunately, we've actually found now that the clinical assessment of bedside practitioners does not really correlate well with cardiac output or systemic vascular resistance. And that is to say that we are really not good as practitioners at telling the difference between warm shock and cold shock. And this has been borne out in multiple studies now. So because of that, we don't throw it out entirely, but we say this clinical assessment should not be used in isolation when resuscitating these patients. And so what do we use in addition to that? Well, the campaign recommends using measures of advanced hemodynamic monitoring in order to augment our clinical assessment. And so these can include things such as using invasive arterial blood pressure, pulse contour analysis. We can use Doppler studies of the ascending or descending aorta to assess cardiac output. We can also use direct cardiac ultrasound to look at shortening fraction. And of course, we can look at central venous oxygen saturation levels. And there was an interesting study out of Egypt with less than 100 pediatric patients where they found that serial echocardiogram, as one of these advanced hemodynamic monitoring tools, resulted in faster shock reversal in patients that presented with septic shock, less fluid overload, decreased length of stay, and decreased mortality. So there is a lot of benefit to using these rapidly advancing tools that we have at our disposal. Now, another tool that we have is blood lactate levels. So blood lactate, in conjunction with clinical assessment, should be used to guide our resuscitation. And we know that lactate does not exactly equal a direct measure of tissue perfusion because lactate can be elevated for other reasons, such as decreased kidney or renal function or abnormal mitochondrial function. So while it does exist in an anaerobic state of metabolism, decreased perfusion, it is not a direct correlation. However, we know that it's a good tool to be used in conjunction with our clinical assessment. And this is supported by some observational pediatric data. A study looking at 77 children found that rapid lactate normalization was associated with a decreased risk of persistent organ dysfunction with a relative risk of 0.4. So that concludes our Chapter 2, looking at fluids and hemodynamic monitoring for patients with sepsis and sepsis-associated organ dysfunction. Next time, we'll dig into a meaty chapter looking at the recommendations on vasoactives and ventilation strategies. So if you like the content you're seeing here at Pick University, please like and subscribe, and we hope to see you next time.